I invite Dr. Prakash Naik, sir, who is Associate Professor, Department of Surgical Oncology, TMH Mumbai. I welcome you, sir.
Thank you so much. Thank you.
Thank you, sir. And to present this today's topic and enlighten our minds, we have Dr. Mukta ma'am, who is Professor, Department of Pathology, TMH Mumbai, who has accepted to give us this talk despite her busy schedules. I welcome you, ma'am.
Thank you.
And to moderate this, I and Dr. Atira shall moderate this. And I express my sincere gratitude to the webinar hosts, Dr. Anta ma'am and Sumit sir, who has taken great efforts in helping us budding pathologists through this online program. Thank you, ma'am and sir. And before we begin the session, a few small reminders and where we should not have any connection interruption. And please try to answer the poll questions only in the chat box. And no direct request shall be sent to the presenters. A few small disclaimers as well. And also a brief reminder of the upcoming slide seminars. We have one on chondroiterations and one on osteogenic lesions, both by Dr. Vikram sir. I request all the postgraduates to join for the upcoming slide seminars diligently. So now let's begin. We have approached bone tumors. And on to Mukta ma'am now. I shall stop sharing my screen now.
Great. Thank you so much. Sumit, I'm really happy to be part of yet another series here. And thank you for agreeing, agreeing to, deal with whatever the circumstances right now. Welcome everybody, and thank you, Prakash, for joining in. It would be great fun to have you, and we would have good discussions. Just let's check in before I go ahead. Am I well audible?
Yes, ma'am, you're audible.
Yeah, should I be a little louder?
No, it's perfect.
No, perfect.
Right. Okay. So then we all have heard about normal histology by Dr. Poonam.
Yes, it's still not shared. Your screen is not shared. PPT, not yet.
Oh, right. Just a sec. Wait a minute.
Yeah, take your time. You can stop sharing and join again. So,
yeah.
Yes. Now you can open your PowerPoint.
Is it visible?
Yes, you can make it full screen. Yeah. Perfect.
Is it now?
Yes.
Can we connect this again?
Yes. Thank you.
Right. Okay. So very difficult topic indeed. This is going to be an approach to histopathology diagnosis of bone tumors. And you can see from the title, the traversing through Haversian canals. The Haversian canals are the ones which are the structures within the bone which carry all the the blood vessels and the lymphatics, etc. So it's for the pathologist and for actually everyone to diagnose a bone tumor is as treacherous as imagine going through those Haversian canals. And the difficulty of diagnosis of bone tumors arises from the fact that they themselves are exceedingly rare. They are 10 times less common than soft tissue sarcomas and constitute around 0.2% of all malignancies. They affect children more frequently, but also the adults are affected at around age of 60 or so. The basic categories of bone tumors are osteogenic tumors, cartilaginous tumors, Ewing sarcoma, metastatic tumors, then the giant cell tumors of bone, and there are certain uncommon tumors. But when it comes to the big fives in bone tumors, we have osteosarcoma, we have Ewing sarcoma, we have giant cell tumor, chondrosarcoma, and metastasis. So these are the five biggies, or the big fives that we have, and all pathologists, however rare the bone tumors are, we must be aware of these entities and their morphology. The challenges in the diagnosis of bone tumors is because there is a considerable overlap between reactive process in the bone, like for example a fracture callus, a benign lesion condition like say osteoblastoma can resemble malignant lesions. Then there are overlap between many different types of tumors, and we as pathologists are heavily reliant on radio imaging for the diagnosis. There is no substitute for multidisciplinary approach, and whatever said and done, however advances have been made in the molecular techniques and immunohistochemistry, when it comes to bone tumors, we are actually grounded where the hematoxylin and eosin 3 informs the backbone and the basis of our diagnosis. And unlike the soft tissue tumors, ancillary diagnostic techniques are not of much help, although a few of them do exist now, which are supposedly specific to help us, but then the caveats exist and there is a problem or the concern with each one of them. So when it comes to approach to the bone tumors, it just starts with one term and ends on that one term, and which is a concept of a team. The diagnosis and the treatment of bone tumors is impossible without the team approach. And each member of the team has to be aware of what are the possibilities in a given clinical situation. Like each of them have to have the perfect knowledge of the current classification, types and subtypes of bone tumors, the clinical presentations of each of the entities, radiology, and of course for the pathologist, only pathologist, the histology as well, variations and spectrum. And when I say only pathologists, there are only select few, like we have Dr. Prakash today, who is immensely interested in histology as well, and you should be blessed to have such a surgeon in your team. But these are very, very rare. So ultimately, it all falls onto you as to how you interpret your histology and how you tie everything, the histology, to your clinical and the radiological parameters. So all that is done with the knowledge and with the awareness that what is the impact of this diagnosis on the patient? What is really going to happen if a given diagnosis is offered to the patient as against yet another one offered to the patient? Okay, and then obviously all of us have to keep up with the recent advances. The histologic analysis and interpretation is never standalone. Always remember that. Diagnosis is not made into your office only looking at the pink and blue and brown images under the microscope lens. No, it is not so. You have to be out in the clinic, you have to be talking to everybody, and only then your histopathology images start making any sense. Otherwise, you will really fall into a big trap, and not you, the patient will fall into a very serious trap. So this is what the approach is, the bone, and this is our bone and soft tissue disease management group at Tata Memorial Hospital. I think this is an old photograph. Prakash has just joined here. I don't know where Dr. Manish is, but the rest of the team is very much here. And these are the people we learn from each other almost every day. And that is the crux of the expertise. And here comes the three Devs, the radiologist, the surgeons, and the pathologist, which form a key role in diagnosis of bone tumor. Unless the three of us are in agreement, no single diagnosis is made. So please remember the three Devs, okay? You have to be in constant contact with the radiologist and the surgeons. Now, the journey through Havisham Canal begins with, of course, knowledge. And knowledge is that what is possible in which bone. That is very, very important. Like within the given part of the bone, where is the lesion? Where is the tumor? Is it in the epiphysis, metaphysis, diaphysis? Is it in the cortex of the bone, medullary cavity? And then again, within the body, which part of which bone is involved? Okay, is it the tibia? It's the knee is unfortunately the commonest site that is involved by the bone tumor. But then each site has its own very specific tumors that arise there, and some tumors specifically don't arise at some sites as well. So the knowledge of both of these is very important. And when I said that we have to be aware of the implications of the diagnosis, we have a spectrum of the managements. There are certain lesions, certain benign lesions, which are to be just left alone. Like for example, fibrous dysplasias and chondromas, unless they are bothering the patient cosmetically or pain-wise, they are just to be left alone and watched. Some tumors like giant cell tumor of bone are curated, some like aneurysmal bone cyst undergo sclerotherapy. But when it comes to the malignant tumors like osteosarcoma, chondrosarc, Ewing sarcoma, metastasis, the management is drastically different from one another. So the diagnosis of just the bone tumor, whether benign or malignant, is not adequate. We have to specify what malignant tumor or what benign tumor we are dealing with, because each has its own management differences. Now coming to the actual core of the talk, where we begin with the morphology. As I said, no diagnosis is even complete. I mean, we shouldn't even be starting to look at the histology before you have the clinical details at hand and you have the radiology at hand. And we actually, at our desks, we are pathologists, but each case, whenever the case comes at our microscope, the first thing that the resident tells us is the clinical history, the detailed clinical history that is available on the electronic medical record. Followed by that, we open the radiology portal, and then we open the images. Thankfully, many a times we do have images available to us. If they're not available at that moment, they can be made available later on as well. But without the radiology, no case is viewed under the microscope. Now, the radiologist and the pathologist speak different languages. They see things differently. See, the pathologist's life is colorful, yeah, and we go near to the tissue as is possible by any of the people in the team can. So we are really, really privileged to have the opportunity to go down, although our images are obviously altered by the staining, but then that's the closest that we can do. On the other hand, the radiologists do see real life images, but they are also altered by the radio imaging techniques. So both of us have different set of eyes which are looking at different information. But when that information on itself is not meaningful, it becomes meaningful when a dialogue is made, it is merged with the clinical information, and only then we realize that we're talking about the same thing by looking at the same thing but in a different manner. So the radiologists themselves have their own ways of interpretation of bone tumors, and what they do is, as we saw earlier, where is the location of the lesion in the affected bone, the size, what is the matrix composition of the lesion, is the matrix osteoid or is the matrix secondarily deposited on a cartilaginous matrix, nature of zone of transition. So this is the key word that the radiologist would often use, and I don't know if Dr. Prakash is going to talk about this. Usually the wide zone of transition means the tumor is widely infiltrating into the bone, and the narrow zone means that the tumor has restricted its position to a part of the bone and it doesn't have an infiltrative potential. Then the presence or absence of infiltration of the medullary cavity of the bone, if seen, it is invariably a malignant tumor, with obviously some exceptions, like for example infective etiologies. Presence or absence of cortical destruction, soft tissue involvement, again, all these are signs of an aggressive bone tumor. So many a times the radiologist may not be able to tell you what kind of bone lesion it is, but it is immensely helpful for us to, even if they tell us that this is an aggressive bone lesion, and in certain instances they can actually tell you right up front when you are struggling with the diagnosis of benign versus malignant that this is malignant. Now you figure out which malignancy, and that is how the dialogue builds up, and that is how we are helping each other in building up the diagnosis and arriving at a consensus. Then the presence of a periosteal reaction as well, the nature of the periosteal reaction and the multiplicity of the bone. So each of these parameters has a lot to tell you. The question is now on a pathology forum, how much radiology should a pathologist know? Should I be an expert in radiology? As I said, I do open each and every radiology image that is available to us on the EMR. The answer to me right now, after all these many years in the BST, is that I really don't have to be an expert radiologist, obviously, because that's not my forte, but I should know enough to ask the right questions to the radiologist and to the surgeons, and I should know enough to recognize the discrepancy between what I'm looking at under the microscope and what the radiology image is showing, or what the radiology report has been made. I should be able to recognize at least that. So the key histologic features. So we are coming to even more core histologic parameters. So we always start it is a given a bone tumor. We know clinical context, we know the radiology. Now we are looking under the microscope. We look at the cell type, we look at its product. And what do I mean by its product? In the context of the bone tumor, is it an osteoid, which is produced by osteoblasts? Is it a chondroid matrix, which are produced by chondrocytes? Is it no matrix at all, and is the tumor just a malignant round cell tumor? Or the tumor is not producing any osteoid? Is it a giant cell rich tumor? Does the tumor have pleomorphic tumor cells? Are there any other cell types like epithelial cells, lymphoid cells, etc.? Is there any atypia? Now this is a critical part, because do not equate an osteoid producing tumor as osteosarcoma. A tumor with chondroid matrix as chondrosarcoma. No, we have to decide after we are deciding what lineage bone tumor this is. The next step is to decide what is the degree of cellular atypia, or are there any signs of malignancy. We are already primed about the clinical history and the radiology as well. Now it is our turn to look at the histology critically and look for the signs of malignancy, if at all there are. And those signs of malignancy come in the form of cellular atypia, mitosis, especially atypical mitosis, signs of invasiveness of necrotic bone, and the presence of necrosis. Now, if you want to take back anything out of this talk, I think this slide is very, very important. That you have your clinical context, you have your radiology, then you decide what is the cell type. Is it an osteoid producing tumor? What matrix is this producing? Is it a giant cell rich tumor? And then apart from this, just then filter out everything, filter out the matrix, filter out the giant cells, filter out the necrosis, and then just concentrate on the cellular morphology. Are the cells atypical? Are the cells, do they have a typical mitosis, and is there a sign of native bone? Presence of necrosis invariably in a tumor indicates a malignancy. And these are the features that you should be looking for before declaring a tumor to be malignant. Now, let us just take osteosarcoma as a template tumor, and in the context of osteosarcoma, let us just discuss a few differential diagnoses, which hopefully would cover a large spectrum of the bones, but it is not possible to cover the entire spectrum here. Osteosarcoma is a sarcoma with osteoid production. It affects younger patients in their 20s. 80% of the OGSs occur in the long bones of the extremities. In the older patients, extremity bones 50% and pelvis and craniofacial bones are also affected in about 20% of patients. It affects the metaphyseal areas of long bones of skeletally immature patients, particularly in the knee region. It is an aggressive tumor with 40% mortality with the best available management right now. And this is one of the classical osteosarcomas, a metadiaphyseal lytic and sclerotic tumor, which is invading the cortex and also the medullary cavity. Radiologist has no problems calling it osteosarcoma, and so we also do not have any problems calling this a high-grade conventional osteosarcoma because it is showing these the osteoid matrix. You see this osteoid matrix? These are the thin filigree. This is what is filigree. Filigree means wires. It's usually referred to the wires of metal, especially silver. So this is the filigree, small cord-like osteoid matrix, but it can form it can take any form. Like you can have blotches of them, but again, as I said earlier, you just filter out the matrix. It helps you to decide that this is indeed a tumor which is producing osteoid for sure. The question is it malignant? That answer is given by the cells and not by the matrix. The cells here are large. They have high NC ratio. Then they have the hyperchromatic nucleoli, and then there are mitosis as well. There are large or typical mitosis. I do not see any necrosis in this area, but it is not mandatory. This is a conventional high-grade osteosarcoma with no diagnostic difficulty whatsoever. Now the problem comes when we are dealing with variants of osteosarcoma, and there are numerous variants of osteosarcoma. Each of this has its own vagaries and own morphologic and diagnostic difficulties. So let us begin with this osteosarcoma, which has no osteoid matrix. Now this is the tumor, which is highly malignant. But can you see any osteoid matrix as in the earlier one? No, it is just a solid tumor with sheets of cells. There are mitosis, high NC ratio, prominent nucleoli. So this is a tumor with no osteoid production. And then this is the radiograph. What do you think of this? Dr. Prakash can tell you that anybody can just tell you that although it is not a classical metadiaphyseal lesion as most osteosarcomas are, this tumor is a diphyseal tumor, but still it is a highly aggressive, destructive, lytic and sclerotic cortical tumor with cortical prey. There is a huge soft tissue component, and the soft tissue is also showing matrix here. So if you show this to any radiologist, and this is the case, I would definitely take to the radiologist because I'm not seeing any osteoid production. I have seen the radiograph myself, but I want to make sure from the radiologist because they are the experts. I am not the expert, and I want to confirm that from them. And of course, I have this tool, which is a SAT-P2, which is strongly positive in this case. It helps me along with the radiologist to call this an osteosarcoma. So you'll ask me how is it possible? No osteoid. Well, it's definitely possible because a biopsy is a small sample of a big tumor, and it can be variable. The placement of the osteoid matrix is variable. So it is definitely possible that you cannot have an osteoid. So do not base your diagnosis on the presence of osteoids. So it's everything that counts. And I'm just coming back to the same point again and again. Now another tumor, again at first glance I thought there was no osteoid, but keep looking at it, and I kept looking at it, and can you see these? These are little streaks of calcifications here. Yeah, can you see that here as well? And there is this necrosis. Obviously, there is no doubt about this tumor being malignant, but then there are these streaks of calcifications. Where are they coming from? So this is nothing but this is a matrix, osteoid matrix, which is getting calcified, and this is a giveaway that this is indeed an osteoid producing tumor. Well, now, for example, if you see this tumor, what would you say? Would you actually call this osteosarcoma? No, it has such a carcinoma-like morphology. It has this nested pattern, or if not a carcinoma, you would think about alveolar soft part sarcoma. This is a nested pattern. Then the cells have clear cytoplasm and malignant nuclei. There is necrosis. So, of course, clinical context is very important. But if you look at this, is it not just a high-grade tumor with epithelioid phenotype? And unless you look at the radiology and unless you have these small morphologic nuances with you, then these are really helpful. So careful microscopy gives away a lot of things. Okay, now let's talk about the SAT-P2. I am not going to say that SAT-P2 is the one marker. This is an immunohistochemistry marker, and I'm not going to say that this gives you the diagnosis of osteosarcoma. But what is SAT-P2? This is expressed in the tumors, bone tumors, non-bone tumors, everywhere where there is osteoblastic differentiation. So it is irrespective of it being benign or malignant. It can be a fracture callus. It can be reactive osteoid in the giant cell tumor, myositis ossificans, which is not a bone tumor. Then benign osteoid-producing tumors, heterologous ossification in the reparative regions, and non-osteoid-producing regions. So it is ubiquitous. All it tells you that there is an osteoblastic differentiation. That doesn't really help the pathologist to decide whether the given lesion is malignant or benign, reparative or not, and even it doesn't really tell you whether it is a bone tumor or not. Okay, but it is really helpful in certain circumstances. Like I just told you that no osteoid matrix. I have strong SAT-P2 positivity. I do have radiograph which is corroborating with my findings, and that is fine. It really helps us. But you have to be really careful about interpretation of SAT-P2. Now, this is a 64-year-old male patient who presented with fracture neck femur. See, that's a big fracture here. It can be seen from a distance. Radiology and clinical impression in our 64-year-old was obviously metastasis or a myeloma. And this was the MRI. A large segment of the femoral head, the epiphysis, diaphysis, and metaphysis are involved. It is a big permeative lesion here. Then the biopsy was done, and this is what the biopsy showed. What do you see here? First of all, there are a lot of blood spaces. Yeah, lot of blood spaces. And these are called as aneurysmal blood spaces. Now take this as this is a aneurysmal blood space. Now what we have to do is to look in between those aneurysmal blood spaces and to see what is happening there, because that is what will define what the lesion is. Aneurysmal blood spaces can be present in many bone tumors. And here we are going down under the microscope on a higher power, and I start seeing something very worrisome. There is necrosis, of course, and then I can start seeing a lot of these large or typical cells with large pleomorphic hyperchromatic nuclei here. Then there were mitosis, necrosis, and then there is some osteoid matrix production, which is rather scant. Okay, and I call this is a I look at the imaging, fine. I mean, it is a malignancy, no doubt, and I call it telangiectatic osteosarcoma. Within a next hour or so, I get a call from the OPD that how can a 64-year-old man in a fracture neck femur can have telangiectatic osteosarcoma? It's not acceptable. Okay, so I looked at the slide again. I didn't have any other differential diagnosis. It was a frank telangiectatic osteosarcoma. But you have to listen to your colleagues when they have some other opinion. You have to listen to them. We actually took a lot of efforts and just ruled out a mix-up. The slide mix-up, the labeling mix-up. We ruled that out. We discussed the case again in the joint clinic, and it was again not acceptable. Telangiectatic OGS with that radiology and the clinical context not acceptable. We repeated the biopsy. It was again telangiectatic osteosarcoma. Okay, so here the point that I'm trying to make is not that I was right. The point I'm trying to make is when there is a discrepancy at any level, listen to it, pay attention to it, and address it. Okay, that is the message that we are going, and I'm re-emphasizing the team approach here. Coming back to telangiectatic osteosarcoma, the differential diagnosis of telangiectatic osteosarcomas are essentially two important ones. One is aneurysmal bone cyst, another is giant cell tumor. And angiosarcoma sometimes can be overlapping clinically between telangiectatic osteosarcoma. Aneurysmal bone cyst has this typical recurrent rearrangements involving the USP6 gene, which is tested by FISH. Then the giant cell tumors, 90% of them harbor mutations in H3A, and it can be detected by immunohistochemistry. So the ABC, aneurysmal bone cyst, has the same age range and location as osteosarcoma. It presents with pain and occasional pathological fracture. It has the medullary location. Secondary ABC-like changes are seen in the older patients and also in other bone neoplasms as well. And that is what the ABC has this potential to complicate the matters in the sense that the primary ABC is treated with sclerotherapy. But if we miss a tumor which is actually different and the ABC component is a secondary component, we will be misled in terms of the management of that particular entity. And another tumor which can mimic aneurysmal bone cyst as well as telangiectatic osteosarcoma, if we are not vigilant, is a giant cell tumor of bone. And this is a very common tumor, very common tumor that you see, at least like in Dhaka Memorial Hospital, we see these very commonly. I'm very sure that even people who are working in the general hospitals do see GCTs are being curated. The incidence of osteosarcomas and chondrosarcomas may be less, but GCTs are seen everywhere. And this is one point I want to make right now, is that please be extremely careful while making the diagnosis of our giant cell tumor of bone, because if we, out of 100 GCTs, even if we miss one telangiectatic osteosarcoma or giant cell rich osteosarcoma, we are doing immense harm to the patient. So this ABC versus GCT versus telangiectatic OGS versus giant cell tumor, giant cell rich osteosarcoma, these are the nightmares for the pathologist if it is not straightforward. Okay, a typical giant cell tumor should have no atypia. It should not have any atypical mitosis. It can definitely have necrosis, but a presence of atypical mitosis is mandatory before you call anything malignant in a setting of a giant cell tumor of bone. So be extremely critical about it. And the giant cell tumors of bone in themselves is a different topic in themselves, and there are a lot of vagaries to it as well, especially in the light of recent advances in its management in the form of denosumab. And I don't think we have the time to address it here. As of now, I'm just going to talk about it in the context of telangiectatic osteosarcoma. Please pay attention to the presence of atypical mitosis and nuclear atypia. If you see any at all, go back to the radiology, go back to your histology critically, and raise a red flag if you cannot arrive at the diagnosis at one point, and maybe we can repeat the biopsy.
Mukta,
Okay. Yeah.
Mukta, can you use laser pointer if possible? If you click on the right side of your mouse, you'll get pointer options. Laser, thank you.
Okay. Now, this is a 23-year-old male who presented with a pain in the left knee. This is an ill-defined osteolytic lesion with wide zone of transition. Okay, again at the diaphysis of the right femur, and there are internal tuberculations. There is aggressive periosteal reaction with Codman triangle. Now, this is the MRI of the same patient. And now, what can you see here? This is the biopsy. You would say, oh, this again looks like a tumor with aneurysmal bone cyst-like areas. These are aneurysmal bone cyst-like areas. You see, they are not true cysts. They are not true cysts, but they are cystic spaces which are filled with blood. And now you're going on the higher board, and what do you see? You start seeing a lot of giant cells. And you see them. There are osteoclastic giant cells. Now, are you going to jump to the diagnosis of giant cell tumor of bone just because you're seeing lots and lots of giant osteoclastic giant cells? And so, are you going to call it either ABC? Is the radiograph like ABC? Of course not. This radiograph is not like ABC. Could it be a giant cell tumor of bone? Of course not. Now, here comes your knowledge of the radiology as well. We should know where the ABCs occur, and this is what a typical the GCTs occur. This is what a typical giant cell tumor of bone is. It is epiphyseal, it is eccentric, it is expansile, it has narrow zone of transition, and there is no sclerotic rim. This is a classic giant cell tumor of the bone. Sumit, can we avoid the request, please, in the middle?
Yeah, I request the audience, please do not touch on the button for annotation. It disturbs the speaker. So do not press that 3D snake-like thing, which is annotation. Mukta, you can ignore that. You can
Yeah. Right, not an issue. So look at this. I mean, is this radiograph like a GCT? Of course not. Even a pathologist can say that. It is not an aneurysmal bone cyst, but yet your histology is showing this. Now, where do you go from here? Where do you go? You just filter out osteoclastic giant cells, okay? And you just go down on the cells which exist here. And then what do you see? You see that there are these other areas which are starting. The part of the tumor actually looked very bland, and the part of the tumor started showing off some other face completely different. This is an aneurysmal bone cyst. It is a closer look of aneurysmal bone cyst. And look at these cells. They are looking plumper. They have abundant eosinophilic cytoplasm. They have these osteoclastic giant cells which are sprinkled in between themselves. And when you look at the nuclei, look at the nuclear atypia. They are large nuclei. They have nucleoli. The mitosis are so many. And this is a giant cell rich osteosarcoma. This is neither a giant cell tumor of bone nor an aneurysmal bone cyst, but it's a giant cell rich osteosarcoma with telangiectatic areas. Now, the key points for giant cell rich osteosarcoma is that it can be mistaken for giant cell tumor of bone with ABC-like areas, and that's the one mistake you need to avoid. Cellular atypia and mitosis are not to be missed at all. Atypia, the problem with giant cell tumor of bone, I hope you don't have to deal with such things, but then you have to be aware that the atypia can be minimal, as you saw in this case. The part of the tumor did not really show too much of atypia to be called as malignant, and it can pose a big diagnostic dilemma. Always fall back upon the radiologic features, and the clinical discussion is important. One caveat about osteosarcoma, like there can be a rolling osteosarcoma clinically and radiologically. Can anybody even doubt that this is not an osteosarcoma? Yeah, and a huge destructive tumor, metatarsal, medullary cavity involvement, a huge soft tissue involvement. But what's the biopsy showing? You see that? These are bone trabeculae, and there is something permeating in between, but what is permeating in between is absolutely all cellular. So this is just a cellular osteoid. That's what you have. And you convey this into your report, and Prakash will look at you and say, what? I mean, look at the radiograph. But yeah, the osteosarcomas are perfectly capable of doing these things. So the answer to that is go to the clinic, tell them that this doesn't just fit together. This could be a cellular part of sclerotic part of osteosarcoma. We have to get another biopsy with good cellular areas, and we did that and got another diagnosis. Now that this is another tumor, the chondromyxoid matrix, do you think this is a cartilaginous tumor? And if yes, could it be chondromyxoid fibroma? Yeah, it does have some lobulations, it does have some condensation, and the matrix is not osteoid. Till now, we just saw osteoid matrix. It is not visible here. What is it? Okay, and this is the X-ray. Does it look like a cartilaginous tumor? Prakash can chip in if he wants to. Prakash, can you?
No, it does not.
It doesn't look like a cartilaginous tumor.
No.
Yeah, so an osteoid-producing tumor, Prakash?
Probably. More osteoid than chondroid.
Correct. So no pattern. The chondroid tumors, again, for the pathologists, we need to learn these terms. These are different terminologies. As I said, the radiologists talk different language than the pathologists. So when they talk about the chondroid cartilaginous matrix, they talk in terms of the rings and the arcs, which are like, the calcified cartilaginous matrix. It's a pattern. So when we go back to this and this, what is it? So this is nothing but this is an osteosarcoma with chondromyxoid matrix. And how are we making that diagnosis? Again, purely it is based on the cellular tibia. These cells are not benign as you see in chondromyxoid fibroma, but they are highly malignant, hyperchromatic, and this tumor did have a lot of mitosis as well. So this is a osteosarcoma with chondromyxoid matrix. Now the problem with this type of osteosarcoma is that on one hand, it can be confused with chondrosarcoma, and on another, which in my own experience can be confused with chondromyxoid fibroma, which is a benign tumor, and the management can be so different, extremely different. Okay. So again, it is sometimes we haven't, in one or two cases, I'm just remembering even right now, we haven't been able to decide what it was till the end. Although we did take the management decisions very well, being aware of this diagnostic diagram. So this is how the chondromyxoid fibroma would look like. It's an expansile destructive lesion with narrow zone of transition. So there is no permeative destruction of the bone, no obvious matrix formation. So this is how the chondromyxoid fibroma looks like. Now coming to yet another variant of osteosarcoma, which is a small cell osteosarcoma. Here the cell type is not epithelioid or not that typical abundant osteoclastic type of cells. Here the cells have suddenly become smaller with small amount of matrix. Now can you see that in spite of the small cell morphology, I am able to see the osteoid matrix quite readily, and it has a striking pattern as well. I really like this morphology. It's very striking. It's almost like a rosette, the giant rosettes. But all those rosettes, if you go and see under the higher power, they are not the neural rosettes. I first thought I'm looking at Ewing sarcoma, and when I went under the higher power, I realized, oh, these are not neuroglial rosettes like in Ewing's, but this is osteoid. So this pink matrix is osteoid. So it is easy for me to make the diagnosis of small cell osteosarcoma in this case. But then believe me that there can be tumors, for example, just take for instance this area where you may not have any osteoid matrix, and there the issue or the differential diagnosis between Ewing sarcoma and osteosarcoma becomes very, very eminent, and you have to apply appropriate immunohistochemistry. Some of the osteosarcomas can show this pattern. Can anybody write into the text box as to what is this pattern called as? Actually, I've written it here. So this is called as an alveolar pattern, okay? And this is the pattern that is typically seen in rhabdomyosarcoma. But this was an osteosarcoma showing same type of alveolar pattern. And this tumor was strongly SATB2 positive, this small cell osteosarcoma, NKX2.2, and Desmin was negative. I really like these rosettes. Okay, so now coming to, as I said, Ewing sarcoma, what do we do? What immunohistochemistry do we do? NKX2.2 is a very specific immunohistochemistry marker. And the utility of SATB2 in this instance, maybe it does have its value in this instance when NKX2.2 is negative and SATB2 is positive. But even then, maybe you cannot really differentiate between an undifferentiated round cell sarcoma in spite of strong SATB2 positive, because that is positive in undifferentiated sarcomas as well. I know I'm getting a little more complicated here, but as of now, just remember that a small cell tumor in a bone without matrix, if the cells are small and uniform, think about Ewing sarcoma. Okay, and the next differential diagnosis, I haven't written it here. I would really appreciate if somebody writes that differential diagnosis in the text box. That is the next differential diagnosis to the tumor which is showing round cell tumor which are uniform and small. If you are seeing a round cell tumor which contains uniform tumor cells but they are slightly bigger, okay, they are showing a degree of pleomorphism and they are showing some nucleoli, you have to think about the osteosarcoma, go back to the radiologist and decide that. But remember, sometimes in spite of ICs, you may not be able to distinguish. Right?
Yeah, peanut in the choice. Answer is
yeah. So that is Ewing sarcoma. Those are synonyms. Those are the synonyms. So the answer is lymphoma. Never forget lymphoma. Okay, and Ewing sarcoma and lymphoma are morphologically very similar. Rosette formation is not a common feature in Ewing sarcoma. Okay, it is a characteristic feature but not common. It is seen in very few Ewing sarcomas. So the approach to a round cell tumor in bone should be in this way. Look at the clinical context, look at the radiology. Okay, and after that, look at your cell type, the cell pattern, and invariably you would require immunohistochemistry. Without ICs, this diagnosis is not possible. So add a marker for Ewing sarcoma, add a marker for lymphoma, and then add a marker for osteosarcoma. If at all, you might add a marker for any other tumor if you feel like in the given clinical context. But these are the three main ones. Okay, and this was the Ewing sarcoma, which is strongly positive for NKX2.2, nuclear positivity, MYC2 membrane positive, negative for PCOR. So let's move on from the round cell tumors to yet another category of osteosarcoma. Now this is an expansile lytic lesion in a 33-year-old old female patient. MRI shows altered marrow signal intensity. What do you see under the microscope? Can you call this malignant? I can at the max say that it is permeating the native bone. This is the native bone and it is permeating the native bone. But as we were discussing all the time, if you look at the cell type, it is spindle cell. And do you see any atipia? I would say not much. I wouldn't have any guts to call this tumor anyway a malignancy. I might call it, so I might think about, is it a esoplastic fibroma? Is it some reparative thing, part of fracture callus? But the X-ray doesn't fit, although it does have this so-called narrow zone of transition or is it wide zone, Prakash? What would you say at this point? I know it's not fair to just show you one image.
No, I think it's absolutely fair. Everything's fair. So here, if I look at broad image, see anywhere where if I look at the X-ray, I'm looking at this periosteal reaction on the top, which is trying to limit the lesion, right? So it tells me that it's definitely a benign aggressive lesion. If I just look at the X-ray, would I call it a benign aggressive lesion versus a sarcoma? I will call it a benign aggressive lesion.
Okay, fine. So it doesn't even fit into any benign aggressive lesion on histology. And this case was discussed in the joint clinic, and we decided to wait and watch for only a few days because we just couldn't call this malignancy. And as Prakash said, there were signs of aggressiveness on the radiograph. Within 2 months, this disease progressed. Within 2 months, and see how the morphology changed drastically at this time. This was a repeat biopsy. So we were indeed looking at a fibroblastic osteosarcoma in first place. So this biopsy was also a part of fibroblastic osteosarcoma. But the dreadful thing about this tumor is that it can look so bland that you just cannot call this malignant. But the second biopsy was not a problem. We could easily call it a sarcoma. Sarcoma diagnosis was not a problem. The strong SATB2 positivity here was really helpful to call it fibroblastic osteosarcoma. Okay, so I'm just highlighting the diagnostic issues related to the diagnosis of osteosarcoma, and along with it, I'm just discussing a few differential diagnoses also within the spectrum of bone tumors and how to approach these tumors. So coming back to fibroblastic osteosarcoma, lack of matrix can be mistaken for non-osteosarcoma, non-OGA sarcoma, and blind spindle cell morphology can be mistaken for some benign condition. And you can just imagine that the impact of the diagnosis, however bland or it looks like, the correct diagnosis is still important since it is treated like conventional osteosarcoma. Now, another variant or another family of OGSS is surface osteosarcoma. Sumit, I think I should be going fast. This is surface osteosarcoma. So we have parosteal osteosarcoma, periosteal osteosarcoma, and then there is a high-grade surface osteosarcoma. Okay, so parosteal osteosarcoma is typically surface OGS, and the histology of parosteal osteosarcoma is peculiar. That if we have these bone trabeculae, this is the part of the tumor. This is not the native bone, and then the interstitium consists of these spindle cells, which again lack a lot of atypia and lack mitosis. And this is the tumor which would be then viewed unless and until parosteal osteosarcoma is viewed in conjunction with radiology. The correct diagnosis is simply impossible because it doesn't look like any malignancy. It doesn't look like any conventional osteosarcoma, and this is how it looks like. And a peculiar thing about parosteal osteosarcoma is it is MDM2 positive, and it would also show strong SATB2 positivity. The chondroblastic osteosarcoma, it can be indistinguishable from chondrosarcoma, especially grade 3, especially in young adults. SATB2 is positive in both, so it is not helpful, and radiology can help to some extent. IDH1 and 2 mutations are present in only 50 to 70% of central chondrosarcoma. So again, the demonstration of that mutation, if positive, it is helpful. Okay, so this is the grade 3 chondrosarcoma that we are struggling with sometimes with osteosarcoma, which are dominantly containing chondroblastic matrix. So again, the problem is solved with the age of the patient, the radiograph, the site of the lesion, the type of the matrix, etc., etc. And all these surface osteosarcomas, especially the parosteal, the periosteals, and central low-grade osteosarcomas, and the mandibular chondroblastic osteosarcomas, are supposedly not really low-grade but refractory to chemotherapy, neoadjuvant chemotherapy. So here, because of their refractoriness, the call for upfront surgery might be taken. I think I do have lots others, but I don't think, Sumit, I don't think I should continue. I'll just go very fast here. This is a benign osteoid-producing tumor, which is osteoblastoma. Again, a huge diagnostic problem, although it's exceedingly rare, but when it comes onto your table, it can really make you sweat. So this is one tumor without radiology, and talking to the surgeons, you shouldn't ever be diagnosing it. Okay, so the osteoblastoma shows proliferating osteoblasts, which are plump with abundant osteoid production, but there is no atypia, no abnormal mitosis. This is a greatest mimicker of osteosarcoma, and radiology is exceedingly important. Fracture callus, again, fracture callus is one big pitfall we should never fall into. Then there are other entities like myositis ossificans, benign osteoid-producing tumors, and heterologous ossification in reparative lesions. Don't mistake that as osteosarcoma. Thank you.
Thank you, Mukta. Miss, there's one question that we can take, I'm sure. Prakash, then you let us have Prakash first. Prakash.
Yeah.
You can stop sharing the screen.
Okay.
Thanks, Mukta, very much. Lovely, elusive talk. Prakash, over to you for a comment. You're muted, Prakash. You can unmute. Sorry, I'll make you. You're not co-host, Prakash. You're co-host. You're muted, Prakash. You are still muted. Hold on. Can you see?
Am I audible now?
Yes.
Okay, so let me just quickly share. Wait. Share this window. Okay, is this visible now?
Yes.
Yes, sir. Yes.
Okay, super. Now let me just tell me if the screen's moving ahead or not. Is it moving now? Super.
Yes. Slides are moving.
Can you make
Okay,
a laser pointer?
I will do that. Okay. Just give me 1 sec. This expand the window. Yes, this is better. Why aren't I getting the laser pointer option here? Okay. I'm unable to switch on the laser pointer option here.
No issues, Prakash.
Yes.
Carry on.
So this was fantastic, and I wish, like, every time I listen to an osteosarcoma talk by Dr. Mukta or anyone from pathology, I ask myself, this is so complex, right? It's not just complex for the pathologist; it's complex for everyone. But then things have got to be simpler. I remember Dr. Mukta spoke about the 3 devs. But let me tell you, there are not 3 devs. There are many slaves, and the only supreme court out there is the pathologist. Everyone else, the surgeon, the radiologist, the nuclear medicine, everyone else is a slave, and all of us are slave to the patient and doing what's best for them. And what comes to my mind, and if you can see on the slide, I've written benign bone, and you must be confused. You must be thinking, well, we just spoke about osteosarcoma. I think Prakash has a wrong set of slides. Why is he talking about benign bone tumors? And I'll come to that in a moment. The key aspect is for you to think like the surgeon would in the clinic, okay? And you ask yourself, when a patient comes with a bone lesion, they will come with a swelling, oftentimes pain, and like Dr. Ramadhan said, sometimes a pathologic fracture. And you need to then ask yourself, fine, they will get an X-ray. Oftentimes the patients will get an MRI even. And what are we trying to look at? When you look at a lesion that has come with some symptoms that's arising in the bone, typically you will get a realm of possibilities. And what do I mean by realm of possibilities? Think like this. Any lesion in the bone will fall in one of these categories, okay? And I've color labeled them, like it's green or blue or orange or red. The green ones are the safest, where you do nothing. You leave them alone or you give them some drugs, they'll be fine. You don't even need to put in a needle. Then you come to lesions where you need to do something about it, but it's something short of surgery. And blue here for the rest of these 5 minutes will be using a needle, where either the interventional radiologist or the surgeon puts in a needle in the lesion and ablates it or scrapes it, and it all goes okay, and the lesion heals. Or you need to do biopsy, where the act of biopsy itself may heal the lesion, or you get more information. The orange are these benign aggressive lesions, where you need to do something to treat the lesion. Just giving them pills or just ablating them with a needle is not going to work. You will need to curette this lesion and fill it, or you will need to resect this lesion and reconstruct it. And lastly are the really bad ones, where you need to do a combination of a lot of things. You may need to operate, you may need to block their blood vessels, which is called embolization. You may need to give a drug in addition. You may need to ablate, and if nothing works, you may need to radiate. So a lot of complications. And what you need to ask your clinical team, your surgeon, is listen, I have this tumor, and as has been said so exceptionally by Dr. Mukta's talk, is these mesenchymal tumors are crazy. And she's just spoken about these osteoid forming lesions. I'll show you a few X-rays. But what you need to remember is any lesion in the bone, either it's lytic or it's sclerotic. Okay. So I need to first find out, listen, is this benign? Is this benign aggressive? Or is this something malignant? At the basic minimum in your head, when you're looking at the pathology slides, you already know that, listen, this is likely not a lesion, which is leave me alone. So it's either something that the surgeons are going to need it or operate. And then you ask them, listen, what do you want from this diagnosis? What do you think clinically is the situation? And that's where the teamwork comes in. And that's where it helps you decide what you want to do with this lesion. Okay. So you ask yourself, is there anything that tells me it's benign? Well, ask the patient, ask the clinician, how long has this been there? Now, if the patient tells you, listen, I've had this for a few years, you're like, well, no matter what I see on this pathology slide, either something has drastically changed in the last few weeks. Short of that, something that's been with the patient for a few months or a few years is very likely benign. It's not likely something that's aggressive. But if the patient and the clinician tells you, well, listen, I've only had this last 3 months and it's really growing, then you know already that this is something aggressive. Whether it's benign aggressive or it's malignant aggressive is something you'll see on the slide. And essentially, if it's malignant aggressive in a bone setting, what we are thinking is, does this patient need chemo? Right? And osteoneurons will need chemo. Chondrosarcoma will not need chemo, but will need surgery. And all these surgeries will be big surgeries where you resect a big segment of the bone and treat it. The rest are something that's benign. Always ask yourself, are there signs of infection? Is this a pseudotumor? Am I missing some metabolic parameters? So in our patho joint clinics or the ORPs, where you have the orthopod, the radiologist, and the pathologist, and always remember, it seems like we are all equal, but really what rules the roost there is the pathologist. Because at the end of the day, if I tell them it's benign, the radiologist tells them it's benign, and Dr. Mukta tells us, listen, I see a sarcoma, all of us shut up, and we treat it like a sarcoma. And why I'm telling you this is the onus on you is oftentimes big. A lot of decisions will be taken on what you tell us. And in that realm, what I've learned the most, that no matter how experienced you are, to have the courage to say, listen, I don't know what this is. I don't understand what this is. I need more information, is oftentimes the best way to go about. The biggest error is to think, listen, I know it all, and I'm going to make a call, because oftentimes an arrogant call, which is less informed by the team, oftentimes will get us all into a big trouble. And the only person important here is not the radiologist, the surgeon, or the pathologist, but the patient. And as long as we have him or her and their problems in the forefront, we'll all be great. Benign versus aggressive, then you ask biopsy or not. And oftentimes all these lesions would be latent, active, or aggressive. Now we're coming to the X-rays. And I'll just take 2 or 3 minutes, give you a ballpark estimate of when you look at an X-ray, what you're looking at, how you go about. Okay. Now here comes the crux of it. When you look at any X-ray, there's a lesion. Okay. There's a lesion and there's a matrix. Dr. Mukta told you about a matrix. Now, what is a matrix? When you have a lesion, that lesion has some cells and some intercellular tissue. In your head, you got to ask, listen, if there's a cavity, what can it be filled with? It can be filled with fat, in which case you'll call it a lipoma. It can be filled with bone, in which case you look at all the osteoid forming tumors. It can be filled with cartilage, in which case you'll have a differential of cartilaginous tumors. I've only mentioned benign because the malignant ones are obvious. In osteoid, it's osteosarcoma, and cartilage, it's chondrosarcoma. Then it could just be filled with fluid, okay, which would be clear fluid, like in a simple bone cyst, or fluid with some blood, where it's aneurysmal bone cyst. Lastly, you can also have something fibrous, which you typically call ground glass matrix. And I'll show you those X-rays. If it's fibrous, we'll have some tumor that has fibrous in its name. It's fibrous cortical defect, fibrous dysplasia, osteofibrous dysplasia. We'll keep the complexities for later. And lastly, tell yourself, maybe it's just cells. And there are some tumors that are exceptionally cellular. And think of lymphoma, think of Ewing sarcoma. These are all exceptionally rich cellular things, which may not have any obvious matrix. And one of the matrix-free lesions that come to mind is something like eosinophilic granuloma, right? Which is very cellular, lots of edema on the MRI, may look very scary on the MRI, but oftentimes if it's solitary, just the act of biopsy will heal it. So in your head, go back, lesion in the bone, there's a big cavity. What could it be filled with? Bone, cartilage, fluid with or without blood, some fibrous tissue or cells. That's it. That's as simple as it is. And remember, fluid can also mean pus. And if it's pus, it's an abscess, it's an infection. Now, is that infection bacterial, tubercular, mixed, or fungal is a separate issue. But at the bottom line, if it's a problem an orthopedic surgeon's dealing with, can't get too complex. It's got to be very simple. So think simple. Ask your surgeon, listen, leave me alone, long time, benign, aggressive, or malignant, and then look at what it's filling with, and then take your deep dive. Okay. Then importantly, you will look at some regions of the bone. Okay. If it's a growth plate that's open, you will always think, oh, this is a young patient. Then you'll only think of lesions that occur in the young patient. And again, if it's in the epiphysis, quickly, if I go back to the previous slide, you think of just these 4 lesions. Epiphysis will either have a subchondral cyst, GCT, chondroblastoma, or primary ABC. Subchondral cysts are green, do nothing, they'll be fine. The middle ones, which are giant cell tumor chondroblastoma, need surgery, which is why they label them orange. And a primary ABC nowadays we treat with just a needle and some injecting of drugs with fluoropsy. They don't need big surgeries, most of them. Okay, and which tells you that you think of green, orange, blue, red zones, and those will tend to solve a lot of your dilemma. And this on the right side of your screen is a biggish image. Now, it's see when we talk about zone of transition. Okay, I again can't get my laser pointer. That's all right, but you can see this thing, right, which is well demarcated. What do you mean by well demarcated? You would say, is it sharply, is it marginating sharply or not? Okay, can I see normal bone from abnormal bone? Yes or no? If you can, it's sharply demarcated. If not, it's not sharply demarcated. Important point. Look at the margins. Is this sclerotic? What do you mean by sclerotic? It's a thick, dense bone. Is this thick, dense? No, it's not. It's very loose. So that tells you it's a lytic process. And giant cell tumor generally will not have a sclerotic margin. They will have a lytic focus, and because rank L-mediated lysis is common, you will not have a sclerotic. And again, this is epi-metaphyseal. It's around this line, which is the growth plate. So it's metaphyseal, epi-metaphyseal, likely GCT. Zone of transition. Come back. Narrow and benign on the left, aneurysmal bone cyst. Now look at these multiple little breaks in the lesion. Okay, trabeculations is the technically correct term. Trabeculations. The left one, you can see how clearly there's like a sharp line that's separating it from the bone below, and you know it's something benign. Again, the middle X-ray. It's metaphyseal. It's not epiphyseal. If it's epiphyseal, chondroblastoma is metaphyseal. Again, benign. Now here there's a sclerotic rim. If you go back, look at the GCT. No dark, thick white line on the edge. Here, there's a thick white line. It's a benign lesion, a chondromyxoid fibroma. Again, eccentric. And Dr. Mukta showed you some beautiful slides on a chondromyxoid fibroma. Now, remember, all of these X-rays will have descriptions on the MRI. And more, we are trying to guess. Even if the MRIs are not colorful, like your slides are, like very eloquently Dr. Mukta said, these MRs have their own grayscale images. It's their own version of color. And there's a lot of information on diffusion weighted, P1, P2, spinning the hydrogen atoms around, which tells you, what is this? Is this fluid? Is this abscess? Is this cartilage? They will have their own radiological MRI signature. Okay, like your signature and it notes you, tumors will have their own signature. And we're all moving towards an era with more and more image processing. Your eyes can only see so much, but the machine can see a lot that's hidden in those pixels. So soon, maybe in a few years, maybe 5 years, each lesion will have some sort of a radiomic signature, which when put along with your X-ray will really tell you what you're looking at. And you look at this right side image. Do you need anyone to tell you this is a quiescent lesion or a bad lesion? It's wide. The entire bone is destroyed. Very clearly, it's a sarcoma. And you see round cells while you know it's a lean sarcoma, right? So X-ray gives you great information. MRI oftentimes will overstep the information with edema, confusions. X-ray is clearer. Never ever miss looking at the X-ray. Always look at the X-ray and only then proceed. Okay. Similarly, the same process ahead. Now you go to the periosteal reaction. And if the periosteal reaction, like I mentioned, is buttressing, it's solid, not broken, it's benign. Look at the middle one. It's irregular, it's broken. And when it's lifted, it's broken. Think of Codman's triangle and the sun ray aggressive appearance. What is it? Every time a periosteum is lifted off the bone, when it's lifted, there are blood supplies. And all those individual blood supply channels are filled with osteoid on the Sharpie's fibers. That's what gives you the sun ray aggressive hair on end appearance. And you know clearly it's an aggressive sarcoma. Okay. Then we come to your beautiful enchondroma. You see this ring and arc with an expanded lesion in the hand. Beautiful classic X-ray appearance of an enchondroma. And once you do an MRI of an enchondroma or cartilaginous lesion, you find T2 bright lesions. That's cartilage for you. And then you start thinking of the realms of cartilage, benign, aggressive. And you'll know in talks taken by Prof. Deshpande, and that will help you determine further. Trabeculated and expand side. Lastly, we come to expand side. Always remember, it's harder to take a call both clinically and pathology for these benign tumors. If it's a sarcoma, the treatment is the same. You'll give chemo, except in chondrosarcomas. You will resect it like a sarcoma, you reconstruct it. The decision is really easy for us, which is why oftentimes, whenever Dr. Mukta, Dr. Poonam are really confused, we tell them, listen, just tell us if it's a sarcoma or is it benign. That helps us take a decision. Okay. And oftentimes you have to think, what are these benign lesions that will look like a sarcoma? ABC, pig, is there a fracture? Did you biopsy close to a fracture? Look at the X-ray. See if there's a fracture. Then ask your surgeon, did you put a needle where a fracture was? If he or she says no, then you know, okay, that's a part of the lesion, not of the reactive process. Okay. And these three ones, the expanding ones are ABC, GCD, where USP6, etc., histone staining, etc., helps you arrive at a diagnosis, because all of these are going to have giant cells with their individual nuances. Okay. And lastly, the fibrous lesions are always dark on T1, dark on T2. Ground glass, that's the mantra. If you see ground glass on the X-ray, and it literally looks like ground glass, universal fibrous matrix, which is T1 dark, T2 dark on the MR, right? And signs of aggression, which is pain. Ask, is this painful? Is there edema on the MR? And is there a soft tissue component? All of these, when you ask your radiologist, tells you this is something aggressive. Any lesion that's broken through bone will likely be aggressive. Now it's 8:13 already. I will probably stop in a minute and we can freelance take questions. This is an osteoblastoma. I'll stop it here to just tell you that eosinophilic granuloma and osteoblastoma, this tiny bitsy lesion, which is 2 mm. Look at the white edema, it's crossing across the lesion. It's reaching till the physis, going down almost to an extent of 10 centimeters. A tiny little lesion. So edema and pain don't always mean it's malignant. If your X-ray shows a classical osteoblastoma, blue, needle, ablate, done, no surgery needed. So I'll close with saying you got to think of green, orange, blue, red. Red are the sarcomas, where a lot needs to be done. Orange are the benign aggressive, which needs some surgery. Green, leave me alone, which ideally should not even be biopsied. That's the importance of doing an X-ray or imaging beforehand. And blue are the ones where osteoblastoma, chondroblastoma, which you can needle and treat. Okay, I can keep going on, but I'll stop my screen share, or maybe I'll keep the screen sharing on, and we can have questions or any comments. If any other, I'll keep the slides rolling so that you get a hint of what does that we do.
Prakash and Mukta, both of you, it's your time. I think there's still 157 pathologists eager to learn from you. I would say 14, but please take your 5, 10 minutes, 15 minutes you want to take. We are more than happy. Yeah.
And while we get questions, I just want to emphasize, see, we talk about these usual exceptions to biopsy in an elite setting, but see, these bones, soft tissue tumors, both for pathology and radiology and surgeons are rare. They're not common. We see tons because it's a reference center. So you may get biopsies of lesions that shouldn't have been biopsies. And just keep that at the back of your mind. That's all. I learned so much from your talk.
Well, so do I, as usual, Prakash. Yeah, I mean, I'm so glad you touched more upon the benign lesions because I didn't have time for those.
Yeah.
So thanks for that. It kind of completed the session. Thanks. So if we can take any questions.
Couple of questions in the chat box.
Yeah, Thira, please go ahead. Yes,
So I would like to address the first question to Dr. Mukta, ma'am. There's a question on, actually not a question, someone had asked to show the last table slide of your presentation, ma'am.
Okay, the last slide, I just kept it in a hurry because it was about the latest changes that have happened in the, wait.
And in the meantime, another question for you, Mukta, is what is the difference between osteoid and native bone?
Oh, okay. So native bone would always retain its lamellar nature. Okay, it would always have the lacuna with orderly presence of the osteoblast, which are extremely small and benign looking. Whereas a malignant osteoid is haphazard. It doesn't have those typical lamellations of the native bone, and that is how and also the degree of calcification and the matrix formation is also different. So osteoid looks pink, whereas if in an undecalcified section, if you cut it, the native bone often looks blue because it has already been calcified. So the presence of orderly lamellations, presence of very small osteoblasts, and the presence of calcific matrix, they are for the normal bone. So this was the last slide. This just I had just put it
Mukta,
to show what are the differences.
Mukta, you have to open the slide.
Okay. Wait. I keep doing that. Wait a minute. Anyway, are there any more questions? If
No.
One more question about radiology science. How does lymphoma and bone look like in radiology?
it looks, I mean, Prakash can take this question, but for us, I mean, there is a lot of overlap between Ewing sarcoma and lymphoma. Both are widely permeating tumors, and they show the so-called mottled appearance on the X-ray. So the radiologist can, or even it can look like chronic osteomyelitis. Prakash, do you want to take it?
Yeah. So yeah, great question. So typically when we look at round cell neoplasms, lymphoma or even sarcoma, the hallmark is that you will have a big soft tissue component out of proportion to the bone destruction. And as Dr. Mukta rightly pointed out, these are permeative lesions. And what that means is in an osteosarcoma, you need the bone to be destroyed, the cortex to be destroyed before you see a soft tissue component outside the bone. For a lymphoma and Ewing's, if you look at the X-ray, you will see a permeative lesion involving the marrow. The cortex may be intact, but clinically and certainly on the MR, you'll see a large soft tissue component all around. And the large soft tissue component all around would be cellular, like I said, and this would be iso-intense on T2. They won't be too bright. So you can make up that is a cellular tumor, large soft tissue component, and that makes us click. Very important point. I must tell you that the reasons why we have to do an open biopsy is very high in a lymphoma. And why? Because lymphomas are so aggressive that oftentimes you get a necrotic tumor on needle biopsies. Okay, and if you repeatedly get a necrotic tumor with the background of some round cell tumor, you really got to start thinking, are we missing a lymphoma? So the occasional instances where a well-guided needle biopsy has failed to give you viable tumor, we often as clinicians think of a lymphoma, and the occasional instance where you do an open biopsy and you've then proven it's a lymphoma. So these are the two bits to share over.
Mukta, we can still can't see your slide.
No, that's okay. I think I
that was okay.
yeah. Right. Thank you so much.
Yeah, there are no more questions here. Mukta, you have any final comments, Mukta, and first Mukta and the second Prakash? Anything for?
No, the final comments as such are the first of all, bone tumors are rare. Whenever you deal with them, be sure that you are talking to each member of the team before you make any kind of diagnosis, and always start in a very systematic manner. Start with the clinical presentation, start with the radiology, and then you interpret the histology. And the cellular features are extremely important. And you have to have the knowledge of the spectrum of the morphologies that each tumor would show. That's all I would say in the.
Thank you, Mukta. Thank you. Prakash, you have anything to final say? Any final words?
Yes, boss. So I learn a lot every time I go to our Pathway JC, and I come back from this message every time, which is to embrace uncertainty, to just embrace stuff that you don't know. And as long as one's extremely comfortable not knowing and accepting that we're uncertain, you'll always have a lot of help around. And I think that'll lead us to the right path, which is so important for every tumor, not just bone tumor, for everything like perhaps. Over.
Yeah, I think in fact I should end with one very important message. Like when Prakash is saying Patho JC, the way we function as a DMG are we get together twice a week. All specialties on Tuesdays, and on Thursdays we have exclusive pathology, radiology, and the surgery meetings, and these are exclusively on for the diagnostic cases. Like we put in our cases, the cases come from the OPD, the radiologist. Everybody puts in their cases where they are finding them difficult, and then we sort out a few of them, but maybe I think maybe 2 to 5% still remain unsolved even after several discussions, and that is where we know that there is a roadblock, and we have to accept. So what Prakash is saying, that those are the roadblocks that we need to recognize, we need to identify, and maybe over the years just learn to overcome them and to still act on them. And that is where the clinical acumen comes in.
Mukta, there is a last question for you and one for Prakash. I'm sorry, they won't leave you. For you, Mukta, the question is how to identify atypical chondrocyte. Dr. Surabhi wants to know that.
Okay, so again, atypical chondrocyte, when you use that term, it means that there is cellularity here. That means in a given cartilaginous tumor, you have increased cellularity, you have increased nuclear size, and don't expect mitosis in a cartilaginous tumor unless it's a very high grade 3 chondroblastic osteosarcoma or an dedifferentiated chondrosarcoma. So mitosis are not a common feature, but increased cellularity and increased size of the nucleus chondrocyte makes it atypical. Now, I think we are going on a huge discussion on benign and malignant cartilaginous tumor. We don't have time for that, but this is what I would be answering to you at this moment. I think Vikram can talk about it much more.
Thanks, Mukta. Vikram has it on Thursday on chondroid lesion, so Surabhi join us. There is Dr. MK for you, Prakash. The question is, any indications to not to do a biopsy, bone biopsy?
Oh yeah, that's a $1 million question. That's a great question, and one which must be taken most seriously. Anytime we say you're not going to do much, you go home, you're fine, is, believe me, a very hard decision in the clinic. Putting in a needle is easy. Not showing something is hard, and we have to take that call. There are some very classic leave me alone or touch me not lesions. Subchondral cysts being one, and chondromas being one, bone islands being one, fibrous cortical defects, non-ossifying fibroma. So there is a small group of about 8 to 10 lesions, and look it up on literature. Touch me not, leave me alone lesions. They have some classical features. Usually they're not symptomatic. They are picked up incidentally. We call it incidentalomas. So if it's a red herring, the commonest is a 60-year-old gentleman or a lady has a total knee replacement scheduled, and next thing on the X-ray they see some chondroid lesion, and you worry, is this something I should be worried about? And that's a red herring, a touch me not, a leave me alone lesion. So there's a list of 8 or 10 such lesions where you're very sure about the diagnosis is, which case you do not do a biopsy. And that's a decision taken by the radiologist and the pathologist. And one last point I have for Surabhi, who asked, next time, maybe in 5 years, you get atypical chondrocyte on your slide, you ask your surgeon, haven't you read the consensus statement? You're not supposed to biopsy these. Stop biopsying these. And so the message is, I'll probably share a consensus statement which all sarcoma units in the world had very recently. It's now published. It's called a Birmingham Orthopedic Oncology meeting. There's a chondrosarcoma consensus. I'll happily share that, which addresses a lot of these issues, which, as Dr. Mukta said, is like opening a Pandora's box on grading cartilage tumors, which we all hate. But hopefully in the future, a lot of us will stop biopsying this. Less trouble for you. Over.
Thank you, Mukta. Thank you, Prakash. I think
thanks a lot.
Thank you very much. I'll just briefly tell you that we have 2 talks coming up, seminars by Vikram Deshpande. Thursday we talk on chondroid lesions, and the next Tuesday we have osteogenic lesions. And then we have a seminar on soft tissues by Raveen Mahajan, and we have 2 talks coming up on skin biopsies, which is followed by lung tumors, lung lesions, granulomas, and then we start with the metal lymphoid. Thank you, everybody. And